Hello, and welcome to Challenges in Embolic Stroke, Identifying Candidates for Patent Foramen Ovale Closure. This continuing education activity is provided by Vindico Medical Education and is supported by a grant from W.L. Gore and Associates. I'm Howard Herman, and I'll be your chair for this activity. I'm the Breyfogle Professor of Medicine at the Perelman School of Medicine of the University of Pennsylvania, where I also direct the interventional cardiology section and the cardiac catheterization labs. I'm joined today by two close friends and colleagues who are both esteemed experts in the field of embolic stroke with a PFO. Dr. John Carroll is professor of medicine at the University of Colorado School of Medicine in Aurora, Colorado. And Dr. Scott Kasner is a colleague of mine at Penn, where he is the professor of neurology and chief of the Division of Vascular Neurology, as well as the vice chair for clinical affairs. Today's program will focus on the best practices regarding the early identification of patients with embolic stroke, including screening tools, risk factors, and evidence-based diagnostic and classification criteria. The most recent guidelines and recommendations for the prevention of recurrent ischemic stroke in patients with PFO will be discussed, along with current treatment options for embolic stroke based on the most recent data. And finally, the latest evidence regarding the use of PFO closure plus medical management compared with medical management alone for the secondary prevention in patients who have experienced an embolic stroke. We'll start tonight with Dr. Scott Kasner, who will discuss with us PFO detection and the guidelines for embolic stroke. Welcome, Scott.
Thank you, Howie. It's my pleasure and honor to be here and to give a perspective on detection and guidelines for embolic stroke. Let me start off with a case. A 49-year-old man presents with mild left face and arm weakness, as well as some mild neglect or inattention to his left side. Other than being an occasional cigar smoker, has no other typical risk factors for stroke. It's also debatable whether or not even cigar smoking is. He has a small right cortical infarction that you can see circled in the picture here. His carotid ultrasound shows no stenosis. His cardiogram shows a normal sinus rhythm. Echocardiogram, transthoracic, shows a normal ejection fraction, no wall motion abnormalities, structurally normal heart, but it shows a PFO, patent foramen ovale. Laboratory studies reveal a very mildly elevated LDL and a normal hemoglobin A1C. This would be qualified as a cryptogenic stroke according to the classic TOAST criteria. TOAST is the name of a clinical trial that defined ischemic subtypes for subgroup analysis. Cryptogenic stroke is a bit of a wastebasket term that includes a lot of things, including patients who have an incomplete evaluation, a thorough but negative evaluation, or multiple competing causes. So cryptogenic has always been sort of a problematic diagnosis. In 2014, a team of investigators got together with the FDA in order to take a fresh look at cryptogenic stroke and to define embolic stroke of undetermined source by requiring a minimum set of criteria to establish the diagnosis of truly otherwise unidentified stroke etiology. This required imaging that showed that the stroke was not lacunar or a small deep infarction in a typical territory of penetrating arteries. Patients had to have a thorough evaluation of the intracranial and extracranial vessels to exclude a greater than 50% stenosis. They had to have an echocardiogram to rule out intracardiac thrombus, but also major high-risk sources of cardioembolism, such as atrial fibrillation, prosthetic valves, intracardiac tumors, severe mitral stenosis, very low ejection fraction or vegetations. And they had to have no other specific cause of stroke identified, such as an arteritis, dissection, or some other atypical cause. By requiring these criteria, the proportion of ischemic strokes that are ESUS is about 15 to 20%, much lower than the 40% shown on the prior slide where I described cryptogenic stroke. So this is really the target population where we're trying to understand the mechanisms and try to figure out where PFO fits in. ESUS, while excluding those major high-risk sources, still includes a lot of things. It's a little bit overwhelming, all of the things that could potentially still account for stroke in this patient population. But PFO, shown here, is actually one of the large ones, especially in the younger population. PFO is a congenital cardiac abnormality that's present in all of us when we're fetuses, persists in about 25% of adults. And it's when fibrous adhesions fail to seal the atrial septum. And if we give this patient agitated saline or a bubble study, we can see the bubbles crossing the PFO into the left atrium. About 10 years ago, the risk of paradoxical embolism, or ROPE score, was established as an attempt to try to identify which patients were most likely to have their stroke caused by the PFO. The challenge here is that if 25% of normal adults have a PFO, how do we know if that's the cause of the stroke or if it's an innocent bystander, an abnormality that doesn't participate in the cause of the stroke? And this is a major clinical challenge in trying to diagnose whether or not the PFO is really the problem or not. So the ROPE score assigned a scale from 0 to 10, where patients got points taken off for age and for vascular risk factors. So a patient could score a 0 if they had multiple vascular risk factors and were over 70. They could score a 10, the maximum score, if they had none of those vascular risk factors and were young, in the range of 18 to 29. All these are clinical factors except for one, and that's the cortical infarct on imaging. Cortical infarct should be embolic, whereas deep infarcts tend to be more likely non-embolic. I'll come back to that point in a minute. But this was an attempt to try to identify which patients were more likely to have their stroke caused by PFO. Let me just go back to this issue about imaging. The image here on the left, where there's a small white dot in the thalamus, I think is pretty clear there. This is a typical lacune. It's a small, deep infarction in the territory of a perforating artery, less than 1.5 centimeters in maximal diameter. Embolic strokes are typically on the cortical surface, as shown in that first slide, but they can also be a little bit higher up than that small lacune shown on the left. And so this image on the right is actually an infarct in a embolic territory. It's not so deep. It's a little bit too big. It's bigger than 1.5 centimeters. And so this is not a lacune. So sometimes this can be sort of nuanced and maybe even complicated, but something that neurologists should generally be able to help distinguish a lacune from a non-lacunar stroke. Our focus here, of course, is the embolic strokes, the non-lacunar ones. So back to our ROPE score. So increasing ROPE score, as was intended, is associated with the likelihood that the PFO is the cause of the stroke. Here you can see that patients with a score of 0 to 3 are very unlikely to have the PFO as the cause for their stroke. That's, again, the older patient with multiple vascular risk factors. The patients with high ROPE scores are more likely to have the PFO as the cause of their stroke. They're the younger patients with few vascular risk factors. This is helpful in trying to assign causality, but turns out to not be so helpful by itself in deciding whether or not to treat or close the PFO, because as shown here in red, the likelihood of stroke risk actually seems to go down with higher scores. Some people initially thought this might be paradoxical, but of course, the older patients with multiple vascular risk factors are highly likely to have recurrent strokes due to those other causes, whereas the young healthy patient should generally be at low risk. Of course, we also have to realize that these young patients who are otherwise healthy have a long life to live, and they want to maintain their health and quality of life. And so even a low risk of a few percent per year adds up substantially over the course of one's lifetime. So we need to redefine stroke etiology. Cryptogenic really means no identifiable or treatable cause. PFO closure, as you will see in the next segment, reduces the risk of recurrence in carefully selected patients. And therefore, PFO-associated stroke deserves its own diagnostic category and should no longer be labeled as cryptogenic once the evaluation is complete. So this is a big change from what we call these strokes in the trials. When you look at the PFO trials, they all say cryptogenic. We no longer mean that. We are really talking about patients who have a PFO-associated stroke. Can we refine this further? Well, ideally, you'd like to see the clot traversing the PFO, as shown in this classic paper in the New England Journal from 1997, where the top picture shows an echo where the T is that blob crossing through the PFO, and the giant clot at the bottom is what was pulled out surgically in this patient. Fortunately, it's extraordinarily rare to see this caught in the act. When PFO-associated stroke was redefined in this recent paper, the Pascal classification system was proposed. It was proposed based on really our intuition more than data at the time. Pascal stands for the PFO-associated stroke causal likelihood classification system, and it grouped patients as clinically definite, not shown on this slide based on the prior one where you see the clot traversing the PFO, probable in patients who have a high ROPE score, so a high likelihood of clinical radiographic attribution to the PFO, and high-risk PFO anatomic features, meaning a large shunt and/or atrial septal aneurysm. Patients were considered to be unlikely to have a PFO-associated stroke if they had neither of those features, and possible if they had one or the other, but not both. So this seemed like a good and logical system, but was not initially supported by data. And so what was recommended to really determine if the stroke was cryptogenic or PFO associated, really, which is our question here, is of course brain imaging as required by ESUS to confirm an embolic appearing stroke. I will digress again and say you don't really want to see too many. Most of these patients are otherwise healthy. You'll see one or maybe occasionally two embolic strokes and an otherwise healthy, normal looking brain. When you see a whole bunch of strokes all over the place, you should really think about other causes, even if that's not immediately apparent, and look hard, especially for cancer or hypercoagulability. Patients, of course, need to have vascular imaging as defined by the ESUS criteria, not just carotid ultrasound, but head and neck CTA or MRA, and a thorough cardiac evaluation, including potentially prolonged cardiac monitoring, depending on other structural abnormalities and age, and we will discuss that. Furthermore, to determine if the stroke is really PFO associated, you really need a TEE to get a good look at the PFO. And then this is typically a young population, so you want to think strongly about doing other things like a toxicology screen to look for drugs because the history may be unreliable, family history for genetic thrombophilia or other genetic diseases. There's lots of weird ones, Fabry's and others, antiphospholipid antibodies, ruling out arterial dissection, and maybe others depending on what else is going on. And this is where you really need stroke expertise to help sort this out. So guidelines came out based on the trials and the clinical intuition that exists. There's still a little bit more data that comes out after these guidelines, but let me tell you what the guidelines say. I tried to summarize them here. They all say to some extent that these patients should have stroke expertise and a thorough evaluation to rule out alternative causes. By the way, the guidelines I'm talking about here are the American Academy of Neurology's guideline in 2020, the American Heart Association, American Stroke Association in 2021, the Canadian Stroke Guidelines in 2020, and the European Stroke Guidelines in 2019. So again, I'll say patients should have stroke expertise and thorough evaluation to rule out alternative causes. As far as closure goes, some are more conservative than others. The American Academy of Neurology, American Heart Association, and Canada all recommend closure only for patients under the age of 60. And they all try to make some specification around embolic stroke or at least non-lacunar stroke. The American Heart Association and Canada specifically recommend closure for patients with high-risk anatomy, and they don't really recommend it for patients without that. So they try to make some interpretations of the data, despite the fact that we really had fairly limited information about the high-risk anatomy, similar to those who wrote the new stroke definition and said that these high-risk anatomical features seem to be important. The Europeans were a little bit more liberal. They recommended closure for patients under 65, so a little higher age limit, and they included those who had a cryptogenic stroke or a TIA or systemic embolism, whereas the others did not. All recommended shared decision-making among neurologists, cardiologists, and patients, so there was high consensus on that. So let me come back to Pascal just for a minute. So again, some of the guidelines embrace this before the Pascal classification existed. Again, feeling that these high-risk anatomical features seemed important, but we really didn't have any data. In late 2021, new data came out based on a patient-level meta-analysis from all of the major trials. This is a project led by David Kent. And the goal here was to see if ROPE and/or Pascal help identify which patients are most likely to benefit from closure or those who do not. ROPE at the top here sort of worked. Patients with a high ROPE score seem to have a greater benefit from closure than those with a lower ROPE score. However, even in those who have a low ROPE score, the confidence interval around the estimate of the effect hits 1, suggesting that PFO closure is beneficial in everybody based on ROPE score. And so that is not so helpful after all. Pascal turned out to be much more discriminating. Patients with probable Pascal category, meaning they have a high ROPE score, patients with a probable Pascal category having a high ROPE score and high-risk anatomic features had a very dramatic reduction, 90% reduction in stroke risk with closure. The patients with either of those categories, so in the possible group of Pascal, also had a robust benefit, not quite as big, but still very substantial. While the minority, the 15% of patients who fit into the unlikely category because they had a low ROPE score and didn't have those high-risk anatomic features, did not really benefit from closure. And so this is very helpful in discriminating which patients are most likely to benefit. Remember that all of these trials tried to include patients who were thought to have PFO-associated stroke before that was really defined. So despite neurologists and cardiologists working together, 15% of those patients were ultimately unlikely to have a PFO-associated stroke in retrospect. And so that really tells us that we should not go hugely outside of those guidelines. We'll talk about what's on the fringes later, but this really does help point us in the right direction of who's most likely to benefit. So, in conclusion, patients with an embolic stroke need a thorough evaluation. Careful PFO detection is a critical part of the evaluation when no other cause is evident. PFO is the cause of some cryptogenic strokes, but not all are pathologic, and so we need to define PFO-associated strokes. And Pascal does that, helps us identify those PFO-associated strokes and identify those most likely to benefit from closure. The guidelines support PFO closure for appropriately selected patients. And as we'll talk about, there's a lot of uncertainty on the fringes, particularly in relation to age limits and the diagnosis of TIA. It's also important to monitor for atrial fibrillation in older patients as something that could be lurking, especially if you're considering pushing that age limit beyond 60. I'll stop there. As we move towards John Carroll's presentation, we'll talk about how we all make these decisions together. So thank you very much.
Thank you, Scott, for that excellent discussion. John is going to now review for us how we identify patients for PFO closure and the application of these treatment guidelines in practice. John?
Thank you, Howie. And Scott, that's an excellent discussion of your perspective, which is so important for everyone out there seeing these patients, that it really is a multidisciplinary approach. So let's dig down into how we developed an evidence base that really gave us more confidence of what patients to treat, but also the risks and the outcomes of the procedure. So I always start with this one patient we saw, and it really illustrates a young patient undergoing the extremely disabling event of a large stroke, resulting in paralysis and aphasia in someone who was an active downhill skier. And also shows another aspect of stroke therapy that's really changed dramatically in the last decade, the ability to do a thrombectomy. And of course, then you remove the clot, and the question is, where did it come from? It is the mechanism of this stroke, but it doesn't say exactly where that clot came from and what can be done to prevent this poor woman from undergoing another stroke down the field. And of course, in the field of PFO associated stroke, there's a pathophysiologic explanation that we all understand, that it's a paradoxical embolism, meaning a clot that develops in the systemic venous circulation someplace, that thrombus then breaks off and embolizes. And with a PFO, it allows that clot to bypass the normal filtering mechanism of the pulmonary circulation. So these 1 to 3 millimeter emboli can go across, can go to the brain, and 2 to 3 millimeters is often the diameter of the middle cerebral arteries. So you can see how disastrous these, quote, small clots can be. And then we turn to, so much has been learned in the last decade and two about PFO anatomy, physiology, and that there are many people with incidental PFOs as presented by Scott. And then there are other people where the anatomy takes on a different shape. An echocardiographic assessment has really helped this go forward. And then as an interventionalist, when you're trying to treat someone who's had a PFO-associated stroke with closure, you've got some additional anatomical variations that can make the procedure a bit more challenging. So the first issue is, how do we detect right to left shunting? That is, how do we visualize that blood is capable of going from the right side of the heart to the left side of the heart without a transition through the pulmonary circulation? And the visualization of microbubbles has really, by ultrasound, has changed things, where agitated saline can be injected, and then we can assess whether it arrives in the systemic circulation, either by directly visualizing left-sided cardiac chambers with echocardiographic techniques, be them transthoracic or transesophageal or endocardiac, or whether we can detect those microbubbles as they hit the middle cerebral artery with transcranial Doppler. And then we want to look at that more exactly. And this is an intracardiac ultrasound image. So therefore, at the top of the pyramid is the right atrium looking across its atrial septum. And look at that septum and how much it moves. So this is a 1 centimeter movement. And we can see that this really goes way beyond full centimeter in its excursion. So it's an atrial septal aneurysm. And notice that after filling of the right atrium, it's only a couple beats later that when the patient takes a breath in, the dynamics change such there is shunting. So those are important characteristics of visualizing and quantifying right to left shunting. And several, the ultrasound societies and other publications have tried to standardize metrics used to assess an atrial septal aneurysm, being 10 millimeters of deviation of this excessive amount of septum primum into one of the atria, or 15 millimeter toe excursion. And then the right to left shunting and the quantification. Number one, it's time dependent, that it has to occur soon after arrival of this bolus of microbubbles in the right atrium. And then the amount of microbubbles that you can count in the left atrium gives a semi-quantitative way of assessing that. And I give in the small, moderate, large, and massive category of the number of bubbles counted in the left atrium. So what determines that? We saw in that previous intracardiac ultrasound image, during inspiration, the septum primum bulged into the left atrium, and that's when shunting occurred. So it's often a pressure in the right atrium being transiently or consistently, as with the Valsalva release phenomenon, that causes the PFO to go more into the open position. But also it relates to the flow dynamics into the right atrium from both SVC and IVC. And this was beautifully shown in this 4D MR visualization, where we see green is flow coming up from the IVC that's directed right at the intra-atrial septum, while SVC flow is directed right at the tricuspid valve. And these admix, but it's why IVC injections of microbubbles often lead to a different quantification of the degree of shunting than upper arm injections. Another thing that's changed in terms of our understanding and our technology is the ability to detect occult paroxysmal atrial fibrillation that may be asymptomatic. And when the major randomized clinical trials were done in this field, it was before we had the ability to do long-term monitoring. The best we had were Holters, but now we have implantable technologies. We have patches that can give several weeks. And again, you have to tailor how long and what modality you choose to what's your assessment of the risk of a patient. And so a 25-year-old free of hypertension, physically active, not obese, that's a low risk category. And so you don't need a month of monitoring. While the older patient who's obese and active with hypertension, there the risk factors for atrial fibrillation are there. But also what comes along with these intensive monitoring technologies is the challenge of integrating a result into the likelihood that someone had a AFib-related stroke rather than a PFO-related stroke. And that can be challenging. But the burden of AFib in terms of the quantification of how often it occurs is a key aspect of that. Technology has improved in terms of the devices that have been developed, and also to the right, we see a suture-based technique. Are they all the same? Are they all, is this just a generic, just close the PFO? Well, the evidence base is extremely varied between different technologies. And we do know some devices have a higher risk of thrombus forming on them. Potentially some devices have a higher risk of AFib. Some devices may have a higher risk of atrial fibrillation. And so it's important to realize that some devices have been extensively tested and some less so, or have been tested and are no longer available. So the FDA obviously looks at this very in depth. And there are two commercially approved devices shown here. And if you look at the formal FDA indications as the text describes, we see typically this represents the clinical trials in terms of the age range, and very importantly also that as determined by a neurologist and cardiologist, and that multidisciplinary approach is really embedded in the FDA indications. And in our clinic, we like to have both of us see the patient during the same visit, which is useful for shared decision making, where the patient can hear two opinions. We can say where we agree, which generally we do, and give different perspectives for optimizing shared decision making. That we found that approach to be very beneficial. So what determines whether the safety and efficacy of PFO closure is a solid evidence base? And it's really these randomized clinical trials, and here's 4 of probably now 6 randomized trials that have produced a high level of evidence. And this is a table from Review in Stroke by Dr. Safer and colleagues that gives you a little idea of, in these 6 randomized trials, they are not always identical. The qualifying event may have included TIA. The cardiac rhythm monitoring, again, in the pre-long-term monitoring era, was variable. And whether their baseline anatomy had to show different characteristics of shunt size or atrial septal aneurysm. Age was similar, sex distribution not that different. And everyone had, it was very common for patients to have some traditional vascular risk factors, but they had to be controlled. But you can see the percent varied from one study to another of these. And then in something like smoking, which is a risk factor for atherosclerosis, it's also a risk factor for increasing the coagulability state of the blood. We see major differences in atrial septal features, where some studies really required these one or both of these high risk features to be present. And then in some, like RESPECT, we allowed patients on anticoagulation, which is an additional factor we'll come to. How large was the benefit for patients undergoing closure in these trials? And we see the results of 3 of the trials that really influenced medical practice. And we see relative reduction that varied quite a bit. The absolute reduction, notice it's fairly small. But again, as Dr. Kasner has pointed out, these are often young, middle-aged patients. We're really looking at a secondary prevention strategy that may play out over not 1 or 2 years, but over decades, which is a very important take-home point. So what about the comparator used in these studies? And it varied, as I showed in the previous slide, in terms of what kind of medical arms were compared, and also realized that PFO arms, despite receiving a device, these patients were typically treated in the short term by dual antiplatelet therapy, and most continued on low-dose aspirin with device in place. So we see here with the trials of the PFO closure, favors the PFO closure, certainly when the comparator is antiplatelet therapy alone. If you turn to full anticoagulation, then we see the therapeutic effect is muted. In fact, does not become statistically significant. Now, of course, there are other long-term aspects of full anticoagulation that are relevant, but this is a key take-home point of what the comparator is, especially if patients are considering staying on medical therapy. Going back to the Pascal algorithm, there are a couple important take-home points where we categorize patients in terms of what we think their likelihood of having a PFO-associated stroke, and we see the relative and the absolute reduction of the risk of recurrent stroke is significant, unlike in the patients unlikely by this algorithm to have had a PFO-associated stroke. But furthermore, we see something that really initially surprised me, that the risk of atrial fibrillation post-PFO closure is actually lowest in those who had probable PFO-associated stroke versus those unlikely. Again, these are perhaps patients who had a paroxysmal and occult atrial fibrillation, had hypertensive heart disease, had other risks. And we also see that while the risk of a kind of a peri-procedure AFib is significant, if we look at the risk of late post-PFO closure AFib, it's dramatically less. So again, a good take-home and practical lesson. Is PFO closure, the procedure and the device associated with atrial fibrillation? Definitely. There's a spectrum, and there's been no device-device head-on comparison that really gives one the high level of evidence to say one device is more likely to cause AFib than the other. Another key important point is that for most of these patients, it's a transient phenomenon and not sustained atrial fibrillation. And again, since these studies did not do intensive pre-procedure investigations with long-term monitoring to rule out occult paroxysmal atrial fibrillation, we don't know how many people actually had pre-existent paroxysmal AFib. So in conclusions, efficacy with the approved devices used in the United States and going through this multidisciplinary approach, PFO closure is not equivalent, it's superior to antiplatelet therapy alone. And over 5 years, the recurrent ischemic risk was lowered from 6% to 1.8%. That's a pretty dramatic and a very clinically and patient-centric, meaningful effect. The safety is there. It is a procedure, so learning curves and training are an important aspect of that. There are some post-procedure, peri-procedure issues, and AFib is the key one that needs to be attended to if it occurs. And so overall, the FDA, professional societies, guidelines as reviewed by Dr. Kasner have a bottom line that the benefits of PFO closure in appropriately selected patients far outweigh the risk of AFib and other uncommon to rare complications. So it is a targeted secondary prevention strategy. It does not prevent people from ever having a stroke the rest of their life. So other risk factors have to be addressed. We know so much more through this intensive period of evidence gathering, and Dr. Kent and the Tufts group really put all the patient level data together to give us some additional information. And this is certainly an area where shared decision making with the individual patient can be nuanced in terms of their preferences, in terms of to what degree patients fit in to the evidence that we glean from these clinical trials versus our outliers. And we have to extrapolate what is relevant to these patient individual situations. Thank you very much.
Well, thank you, John, for that excellent summary of the data that we have to date on treating patients with PFO-associated stroke, and also for helping us to review the identification of patients who may have PFO-associated stroke. You've raised a number of issues, which I think we can discuss now and look at these data in some of the situations where we don't have perfect data and discuss our approach to them. So first, John, I'd like to go back to a couple of your slides where you discussed two issues that I think are relevant to the patients that come up in the clinic every day. One had to do with the difference between anticoagulation therapy and antiplatelet therapy. And secondly, the fact that all of our trials excluded patients who had known hypercoagulable disorders. And so in practice, we do see patients who have hypercoagulable disorders, or patients in whom we may suspect they have a hypercoagulable disorder, but in whom our current tests didn't demonstrate that. And one could argue that these patients are at even greater risk of future events and should get a closure device, but we also don't have much data on the safety of these devices in these patients. So how do you approach the patient with either a known or suspected hypercoagulable disorder and a stroke and a PFO?
It's a great question, Howie, and a challenging one. And I would add, patients who had overt DVTs or pulmonary emboli were also excluded from these studies. So they really had a fully manifest state of thromboembolic phenomenon. So I think individualization of hypercoagulability testing is appropriate. I think Scott pointed out that in young patients, certainly if there's any hints of a hypercoagulable state, like a prior history of DVT or miscarriages, potentially suggesting a woman has antiphospholipid antibody syndrome, or if in a family history you detect a lot of thromboembolic disease. Those are people where it is appropriate to go and perform the myriad of testing that can be done. You should always ask yourself, to what extent will this influence my decision making or not? In some of the trials, minimal hypercoagulability testing was performed. So it's not that we learn from the clinical trials how extensive we needed to do hypercoagulability testing. Scott, how do you feel about that? Because this is part of a stroke workup.
Yeah, I mean, it's again sort of implicit among ESIS and the ROPE criteria, et cetera, that we're looking at patients who we didn't find another source of stroke. If somebody's 50, the likelihood that they have something like antithrombin 3 deficiency is vanishingly rare, right? But antiphospholipid antibody syndrome, this could be the first presentation on anybody. So I kind of think all these patients should get tested for antiphospholipid antibodies. The genetic testing is a little bit more fine-tuned based on maybe age, prior history, family history, even race and ethnicity seem to play a role in some of those things, with some groups having higher probabilities than others.
I'm always a little bit worried about the safety issue as well, that we don't know enough about putting a potentially thrombogenic device in the left atrium of a patient and what that might be. It is a venous system essentially in the left atrium. It's a slow flow, low pressure system. And I think I worry a little bit about the risk of forming a clot on a device, which is very hard to treat frequently in these patients. And then balancing that with the fact that they might need oral anticoagulation anyway. So I think an individualized approach is definitely recognized as important, but I'm not sure we have perfect answers even in those individuals.
I just say there's a bit of psychology, I suppose, in this too, right? I mean, the data would say closure is clearly better than antiplatelet therapy. The anticoagulation seems to be maybe better than antiplatelet, might be sort of in between. But if a patient has a clear indication for anticoagulation, it's not clear that closure helps. On the other hand, they may also be very stressed out about the idea that they have some hole that could be treated. And I know sometimes managing that is a challenge as well. I generally try to tell patients, if you need to be anticoagulated, then that's your therapy, and you don't also need PFO closure. But again, I know that sometimes happens on
yeah, I mean, there is a little bit of the belt and suspenders approach too, that if one is good and the other one's good, maybe the two together are better, and we just don't know.
Yeah.
So another issue that I find a bit of a conundrum now, and I think the Pascal data, helpful as it is, has actually muddied that a little bit, is what to do with the patient who has a low risk PFO, small shunt, or a couple of bubbles that get across, no atrial septal aneurysm. They have a relative risk reduction from the trials and from David Kent's data that suggests it's similar, but their absolute risk is much of benefit. The absolute benefit is much smaller. So how do you deal with that? Let me start with Scott. And does age matter in that discussion? And how do you share that decision with patients?
Right. So you're talking about the patient in the Pascal category who has low risk anatomic features, but maybe has a high ROPE score. So they're young with few vascular risk factors. And I think, the benefit does seem to be there based on this meta-analysis. We looked at it kind of coarsely, right? It's greater than 7 and less than 7, or greater than or equal to 7, less than 7. We're very binary about it. And it's probably a little bit more graded there too. You could have a 32-year-old who's had diabetes their entire life, and they're probably not really a PFO-related stroke. On the other hand, you could have a 55-year-old who has the same score, but has no vascular risk factors, runs marathons, is in perfect shape. And so I think those things start to play a role there. And in these trials is a relatively small number of events. That's what really drives all this analysis. We just don't have that level of detail to kind of calibrate the model.
Yeah, and I would add to that, we're really talking about the heterogeneity of treatment effect. which is based on pooled data from multiple trials, and it shows statistically significant differences, but that does not translate to everyone who's got a probable PFO-associated stroke of all having benefit and never having another stroke. And the flip side of that, of people with, quote, an unlikely PFO-associated stroke, it doesn't mean that all of them would not benefit from PFO closure. And that gets into the nuance and the responsibility of the caring clinicians to really talk to the patient about how clearly we thought they had a PFO-associated stroke and the likelihood of benefit. And as shown by the Pascal data, the likelihood of having peri-procedure AFib. So this is, I think, how the field has advanced in the last 5 years of demonstrating with the pooled data, this heterogeneity.
And I think what Pascal does tell us is that I think we can tell the patients who's in that probable category, we're on very, very strong footing. They are low risk for the procedure. They are very likely to benefit. That's an easy one, short visit. The unlikely ones, that's a tougher one, right? We didn't find the cause for your stroke. You've got a bunch of risk factors. You look like you have a smallish PFO. I'm not really convinced that it's going to benefit you, and there's a higher risk. That's a complicated discussion. And then those possible ones are in between, and they're complicated too. So I think Pascal's really helpful with the probables. It's probably pretty helpful for the unlikelies, and it still leaves us with a complicated discussion for the rest. And they're the majority in reality.
And that brings out the importance of patient preference, because patients sometimes will say, I really would prefer not having a procedure, staying on medical therapy, versus others say, I know it's not a big PFO, I want it closed. That's where shared decision-making brings out differences in patient preference.
For the probables who are risk averse, who don't want the procedure, I think we now have a stronger footing to say, look, there's really compelling data that supports it. And for the ones who are like, you got to close this thing, even though I'm, 70 with, 150 pack year history of smoking, you might say, you know what, I know you're all excited about this device, but this is really maybe not the thing for you. So I do think it really helps these conversations in a way that we didn't have before.
So you brought up the procedure itself, which is now pretty low risk procedure in experienced hands. It's really a half hour, 45-minute procedure. We do them, as you do, John, as an outpatient, utilizing intracardiac echo and conscious sedation. Patients go home a few hours after their procedure. The procedure itself has become pretty routine, pretty low risk. But the post-procedure care is still a little heterogeneous. Could you comment first on how do you treat your patients post-procedure who don't have any other indication for anticoagulation? Do you use dual antiplatelet therapy, single antiplatelet therapy? And then let's discuss the management of palpitations and AFib post-procedure.
Yes. So we use dual antiplatelet therapy for at least 1 month and often 3 months. You want to make sure people don't have bleeding problems that would be problematic. And then we transition everyone to long-term low-dose aspirin therapy because it does cover other stroke etiologies. Again, PFO closure is a very targeted therapy. And while in the 25-year-old with high-risk anatomy, taking aspirin forever may not make sense, but in a 50-year-old, it may have a greater impact. So that's our general approach. Palpitations are not uncommon. In probably 5 out of 100 patients, they do have palpitations, and you do have to figure out what's causing them. Is this transient or sustained atrial fibrillation, or is it frequent PACs? And then you have to stratify what you're going to do about it. Most of the time they resolve. And again, this goes into the healing phase after inserting a device. You've got some transient, usually disturbance in rhythms. You've got a need for the device to get endothelialized, and in humans, it's probably a slow process that takes months, if not years, and allows us to back away from dual antiplatelet therapy and SBE prophylaxis. So there are these post-procedure issues that you start out with a standardized approach, and then you individualize them depending on how the patient's doing. How about you, Howie?
Yeah, almost exactly the same. I use dual antiplatelet therapy for 1 to 3 months and then switch to a single antiplatelet agent, usually low dose aspirin. And I think, as Scott will attest, since we know that many strokes of undetermined source do not have PFOs, patients who don't have PFOs. And so the treatment of those patients is aspirin. And so we're covering ourselves for those possible misdiagnosed undetermined strokes that aren't PFO associated. The palpitations and AFib that occurs transiently in many of these patients, I do think of as more benign than AFib in patients with cardiac diseases or elderly patients who have PAF. And I don't think they have the same risk of stroke as PAF in other settings. Mm-hmm. So I generally don't switch people immediately to an oral anticoagulant. I usually add a beta blocker in that setting, which I think often controls their APCs and some transient episodes. But if it's persistent or lasts more than a day or two, then sometimes we do add a direct oral anticoagulant and cut back one of the antiplatelet agents at that point. But it's really flying by the seat of our pants because there really isn't any data on this. But the good news is it almost always resolves and it's almost always benign. One other issue that I think is troublesome in the clinic to all of us are the patients who come in for primary prevention of their PFOs and for migraines, which we mentioned briefly. There's not much data, but I saw a patient just a week ago whose sister had a stroke. I closed her PFO and prompted her sister to get an echo, which demonstrated a PFO. And she does not have a stroke, does not have a neurologic syndrome, but she wants to have her PFO closed. So what do you tell a patient like that? And maybe Scott, start with you, Scott. How do you approach the patient who has a PFO and maybe a relative who had it closed and wants you to recommend closure?
It's a brutally hard topic. Migraine research is really challenging because there's no objective test for migraine, right? It's patient self-reported. There's a lot of placebo effects and those kinds of things in those trials. Having said that, right, there's this well-established clinical experience that patients who have migraines and have their PFO closed for some other reason report a reduction in migraine, and at least one trial that suggested benefit in a secondary endpoint. On the other hand, as we've been discussing this whole time, we've been trying to find the sweet spot for safety and efficacy in patients with stroke. And we've finally achieved that, and it's not everybody with stroke. So the idea that we would then extend this to patients who have a non-life-threatening disease like migraine is a big leap. And to me, I think we need much better data, patient selection, randomized data before recommending it for everyone, or for anyone for that matter. And so I get that, like, I can imagine this patient's sister wants to now have closure because she's expecting that's going to be effective. And I can't really recommend that, but would like to see more research on the topic.
You ever treat a patient like that with low dose aspirin, Scott?
Not typically, because there's PFO, stroke, and migraine have this sort of bizarre love triangle, right? The patients with PFO are twice as likely to have migraine. Patients with PFO more likely to have stroke. Migraines more likely to have stroke. What's exactly the cause? But no, it's not really clear that migraine patients really benefit much from aspirin. So I usually treat them with migraine prophylaxis, and there are a lot of choices, a lot of drugs to try before you get to doing some kind of invasive procedure.
And continuing down the pathway of post-procedure care, John, when do you get a follow-up echo? What kind of echo do you get? And what do you do if it's abnormal?
It varies on the distance some patient may live. If I have complete closure immediately at either intracardiac echo at the end or before they go home doing a transthoracic with a bubble study and see no bubbles, then I will wait until maybe 6 months to confirm the durability of that complete closure. If someone has residual shunting, and often with Valsalva, you can bring that out immediately post-procedure, then I may look at something before 6 months to see the degree to which they have residual shunting, and then that would determine whether I do follow-up echoes or not. If I see complete closure, or if I see a trivial, like 2 bubbles in the left atrium, then I kind of feel that with the current devices, I don't have to do follow-up. I think in the new era, potentially of bioresorbable devices, et cetera, we may have to rethink our monitoring for the degree of complete closure and residual shunts. When do we do anything about a residual shunt is a more complex issue. And if I saw a substantial shunt in someone 6 months post, first of all, you want to make sure that they were not having any events. And then if it was really substantial shunting, I might recommend a TEE to look at what's going on. The group from Canada, Toronto and Montreal, actually found an interesting development in that some of those people with residual shunts actually have a second site of shunting, intrapulmonary shunting. So you've got to stay open to whether there's something else going on, not be fixated simply on PFO. Whether residual shunts that are through a PFO are harbingers of a higher risk of recurrent paradoxical emboli and strokes is a bit unsettled. There's some observational data suggesting that there is a residual risk. What you do about it, a second device, we don't know. That's anecdotally. What do you do, Howie, in someone you see?
Yeah, I think you raised a couple of points in that discussion. One is that people with PFOs may have other associated abnormalities, a second hole, a anomalous pulmonary vein. We find other things. And so I think it's really important that everybody gets a TEE as part of their stroke workup, which isn't routinely done everywhere. And I think it's important both to make sure that they don't have some other oddity, as Scott showed in his presentation, myxoma, vegetation, but also second holes. And then in follow-up, I don't get a study right after the closure because they're so often abnormal that I'm not sure whether it's the device or not. And so I wait until 6 months and do a bubble study. And if it's substantial at that point, then usually a TEE to look at it and see if it's late passage of bubbles and maybe they have a pulmonary AVM. Or if it's very small and it's just a few bubbles, I just reassure the patients that it's unlikely they're going to have a stroke with that degree of shunting. And I don't usually follow it up, maybe another one a year later, just to see if it's sealed. But I don't really worry about those patients. But if they have a substantial shunt still at 6 months, then I think you have to look a little further at what's causing it. Let's just talk a little bit more about the older patient. So the data and the guidelines differed a little bit on that, Scott. The European guidelines, I think, allowed up to age 65, and the other guidelines tended to stick to the trial inclusion criteria of 60 and younger. But it isn't crazy to see a patient 70 who has no other obvious risk factors, even though you might think epidemiologically they do. Should we be closing patients in that age group, in the older age group? And give me some thoughts on age in the older population.
The guidelines will always be based on the best available data and trials. And the trials, 5 out of 6, only included patients up to 60. 1 included older patients, but ultimately had relatively few. And so it's no surprise that the guidelines stop at 60. The trials were designed that way to maximize the likelihood of getting patients with PFO-associated strokes before that was really a defined term. But it's far from perfect, right? We're using age as a proxy for other competing causes of stroke. There's for sure patients in their 60s and even 70s who are robustly healthy, no other vascular risk factors, normal looking vessels, normal looking heart, normal looking brain, with the exception of one small embolic stroke. And you have to think hard about those patients. Again, we don't have randomized data. We have kind of the pathophysiology to say, this seems like a PFO-associated stroke. We think we can put in a device with good safety. We don't have a lot of safety data in the older population either. So, age is again like a grain of salt. It's a guideline. It's not the law. And I have referred patients well above the 60 age for closure in clinical practice.
Well, this has been a incredibly useful and educational discussion and set of data that you've all presented tonight. We've come a long way in the PFO world since the Closure 1 trial about 20 years ago, when we were putting in devices without really understanding what we were doing and had a trial that didn't show benefit. And now we have such a robust evidence base that we're really working on the fringes of benefit and some of these difficult clinical scenarios that we just finished discussing. So thanks again, John and Scott, for your excellent presentations and insights. To all of you, I want to thank you for watching and hope this discussion will be helpful to you in your daily practice, and remind you that you should participate in the post-test evaluation on the platform in order to claim your CME credit. Thank you, everybody.